company I work for is an overarching legally incorporated federation across the whole of Sheffield. We have, I think it's at the moment, 84 practices in the city, and every practice that can, i.e. a GMS, PMS practice that has the right to, has a shareholding relationship with PCS, Primary Care Sheffield. We've been in existence now for just over 2 years, and our first big contribution to the health and care system in Sheffield was to land £9.3 million out of the Prime Minister's Challenge Fund and give ourselves an enormous headache in terms of delivering a very complicated programme, which I'm going to talk a little bit about, but really what I want to concentrate on is the legacy from that programme, from the learning that we had from that. But what we were really interested in trying to do was stimulate change, try and test out under some fairly favourable conditions what difference we could make by testing a much more integrated model of health and social care. What we were interested in as a company as well was, given that our relationship with the practices in the city, could we do something about testing the ability to deliver primary care, general practice particularly, at scale? So they were pretty big aims in the first place. So we delivered a whole raft of schemes. Some of these were delivered directly by ourselves. Some of them were delivered directly and with and through general practice. Some of them were delivered with some of our other partners in the system, the acute trust, social care, the mental health trust, the voluntary sector, community pharmacists, and so on and so forth. The point I'm trying to make with this slide is to say that we didn't just see enhancing primary care as being the responsibility of general practice. It was about the whole system. The core component of our bid was this idea of delivering enhanced access to general practice. So we set up 4 satellite units around the city. We tend to call them satellite units hubs. It's different words for the same effect, really, of providing same-day urgent access to general practice. And our basic premise was, if we could distribute some of the load, some of the demand that we've been talking about today, in hours and out of hours, that doesn't need the relationship medicine bit that long-term condition management particularly requires in terms of patient need, but relatively lower level need, same day urgent demand, the stuff that when the phones go mad at 8 o'clock in the morning once they're switched on, that drives most practices to despair in terms of handling, could we distribute that through the evening and the weekend? And we'd no idea, by putting 4 units in and operating the hours that we set them up for, whether that was too much, too little, wrong place, and so on. The whole point for that first 12 months was just to test this and see what we learned. Our biggest learning point, really, before we even mobilised, was, would the GPs buy into it? We've been encouraged to go for this by the CCG. We've been encouraged by some of our GP leaders within the city. But the 450 GPs in the city, the 84, 87 practices it was when we first started, would they buy into this model? And we had one of those really signal moments at Sheffield Wednesday football ground. Anybody that's a football fan, apologies for saying that, but we had this meeting where, in a room this size, probably slightly bigger than this, we were absolutely rammed to the gills, because I think everybody was there to either shout us down or to pat us on the back and get behind us. And it was one of those really signal moments where actually the groundswell was, we'll go for it. So I'm really proud to say that we run these units now, and we've run them for nearly 2 years now, without reliance on locums. We run them from the GPs in the city, and I think that's absolutely critical in terms of building them up, sustaining them and developing them and going forward. But what we've also done over time is we've started to put practice nurse access in. We tried AMPs because we thought that would be a much more cost-effective way of doing things, but AMPs don't work in Sheffield for some reason. It just does not work. We wasted, actually, I have to say ashamedly, wasted quite a bit of money trying to make it work, but we just couldn't fill the capacity. And that might be that we put too much capacity in. It might have been the way that the model was set up didn't work. But I think we were all really surprised that we couldn't get AMPs to buy it. So we now run it with a mixture of GPs and a mixture of practice nurses. GPs are still providing the services in the evenings and weekends for clinically triaged patients. You can't walk into these services. You have to be clinically determined as being an appropriate type of individual or appropriate level of need to be seen in these units. And we fill them pretty full. So first 12 months we delivered over 30,000 appointments. Our capacity was more than that. It was nearer 40,000, but we actually filled somewhere in the region of 3/4 of it in the first 12 months. The takeoff was quite slow. We had embarrassingly at times, so much capacity, it was like, this is just really embarrassing, can we go and find some patients? But the system was getting used to it. We fill it now pretty well. Certainly in the week, we're up to about 95% utilisation plus. Weekends, we get that classic fall off on a Sunday that everybody that's been testing this kind of approach has found. Sunday afternoons are a complete and utter wipeout. We have to stop doing that soon, or we have to scale it down, because the demand is just not there. Sunday lunch is much more interesting than going to see the GP. That's my conclusion. Patients absolutely love it. And that 90% approval rating isn't our view. That we've had Sheffield Hallam University evaluating all of the 16 schemes that we ran through the programme. That was their assessment. They really scratched quite hard below the surface to try and disprove this, because they didn't believe it themselves. But that is a really, really positive rating. Impact on the wider system, which is the bit that I'm really interested in. Have we stopped or reduced avoidable A&E attendances? The self-reporting suggests 30%. Frankly, I don't believe that. I think it's much nearer to what the national evidence suggests, which is somewhere around 10 to 15%. That's what Mott MacDonald have picked up from the Wave 1 and Wave 2 sites. It's what Manchester picked up from their much more detailed and much more comprehensive local assessment. I think that's where we are. Interestingly, I think we're making a bigger hit with children than we are with adults. Our demographic is completely different to what ED gets, and I'll show you a couple of slides in a moment to enhance that. 25% of our demand at the moment is children under 18, and a big chunk of that is children under 5. So we are seeing something completely inverse to what EDs are seeing, where the older you get, the higher the number of attendances is. Ours starts to tail down at around 65, 75. We do get older people attending, but again, unsurprisingly, evenings and weekends, if they need to be seen by a GP for a relatively low-level need, they'll wait. It just doesn't present. What we have seen as well is in some of the more deprived parts of the city, we've actually seen some improved levels of access. So I just want to sort of demonstrate that with a couple of heat maps. Basically, the darker the colour, the redder. This is ED attendances over the first 12 months that we set up the units. The bits where it's darker red are the more deprived parts of the city. They are also where the Northern General is, where the adult A&E is. So there's all the classic things of deprivation and proximity will drive activity towards the A&E department. And as further out you get, the lower the numbers are. And northwest, that's where the sheep graze. So don't think that's a big area where there's no need. It's sheep, it's field, it's the Peak District basically, or the start of the Peak District. This is the same time period in terms of our demand that we've seen in the satellite units. It's a much calmer map. So just wanted to sort of comments in terms of lessons learned. I think our learning with the practices has been absolutely staggering. The fact that we're still running the existing satellite service that we set up just under 2 years ago. The fact that 79 out of the 84 practices are still signed up to deliver the activity in those units. The fact that we don't contract with GPs individually, we contract with practices. So practices take their share of the load. They can work out themselves how they want to do it, and they work out themselves what to do with the money in the first place. We don't tell them what to do. Somebody asked me what the rate of pay is. I don't know, because the practices determine that themselves. We give them an allocation, fair allocation. It's just purely on per capita, and they work out themselves how they do it. I think we've had a really successful engagement with our population. Big confession. If you ask me what the spread, what the evenness of the spread is in terms of demand across the practices, it's very uneven. We've got some very converted practices that have absolutely bought into the idea that this is a way of transforming the management of their demand. And we've got some real naysayers that either because they operate in a way where they can consume a lot of their own smoke, or because although they're signed up to it, they still think it's their responsibility to manage their patient workload. And we're still on a journey here to say, how do you get access to how do you use this, and how do you make it as fair as possible? I think we've had really successful engagement with our commissioners, particularly NHS England. I have to say the relationship with NHS England in terms of delivering what we've been doing has been fantastic. I think we've been incredibly successful in terms of developing the service model, but we've done it still, despite running a partnership-based programme, we've still done it in relative isolation. We have in the city, I'm going to get shot for saying what I'm about to say. We have too much provision of out-of-hours urgent primary care in the city. We have the 4 satellite units, we have a walk-in centre, We have our existing GP collaborative. We have two emergency departments, an adult and a children's. We have a minor injuries unit. It's bonkers, it's absolutely bonkers, and that needs to be one pathway for out-of-hospital urgent primary care. So we're absolutely convinced that what we've learnt so far, that, and there is a degree of bias in this, so I fully own that all of that out of hospital should be delivered and owned by primary care, should be delivered and owned by general practice. Our teaching hospital currently owns the out-of-hours service. Don't understand that. It's a truly commercial provider that provides the walk-in centre. The teaching hospital owns the walk-in centre, the minor injuries unit. They're the wrong providers. With all due respect to hospitals, they're great at hospital care. They really do not understand the system outside of hospitals. So the fact that they're owning big chunks of it just doesn't make sense. It all needs to be owned and led from. Now, we think we're in a perfect place to make that offer, and there's a huge degree of bias in that we think that as an organisation representing and covering the whole of general practice in the city, that we can take that on now. We've done it for 2 years. I feel like I'm making a bit of a pitch to you here, actually. But there is something about general practice, primary care owning all of this and developing and moving forward.
And what we're going to talk to today is particularly around community pharmacy, but we're also working quite heavily around pharmacists in practice and what that has to offer and how we can blend all these things going forward. This all started off in about 2013. We looked at thinking about, what is it we can do in the urgent care system to take pressure off both GP practices, but also into 111 services, etc. And we came up with 3 basic areas. The winter ailments activity, which is looking at pharmacy medicines and general counter medicines, and how that we may be able to take those out of the system in terms of people coming to GPs because they want a prescription for those medicines. Then we looked at PGDs in terms of prescription-only medicines, and they're particularly for urinary tract infections, impetigo, nappy rash or thrush bacterial conjunctivitis. So looking at how we can take those out of the system as well. And again, around emergency supplies, how can we make sure that those don't go to the wrong place? And you'll see as we go through this chronology that actually what's happened is the service has morphed and changed depending on the circumstances that are hitting us as a system. So in 2014, the Prime Minister's Challenge Fund came along, and we decided at that point that we could expand this service away from Western Devon, which is around Plymouth, across the whole of the Devon fraternity. So we expanded the service then with 2 different funding streams going on and keeping the same one in Western. Then we had an evaluation. And what was quite interesting is we had an absolute massive patient satisfaction, 100% were happy to recommend. But we found that actually that early bit, the pharmacy and general sales list medicines, quite a lot of the people would have bought those anyway in terms of 40%. So it starts to become difficult to justify. And also we saw some real quite clear impact on the urgent care system out of that work. So we did this in-depth audit looking at, how do you hear about the service, what was done about the service, and in terms of it, why are you requesting these areas. And we found that actually over a period of about a year, just over a year and 3 months, we had an impact of a potentially 17 to 18,000 appointments saved across the system. And they were in general practice and out of hours. You can see the spread. So it's significant. So that the actual return on investment here is quite profound. But we also recognised that looking at those winter ailments, you really find it more difficult to justify those PGSL, A, because a lot of people would have bought them, and B, because we've had quite a shift over the last year or so towards self-care. You can't justify as a system GPs now starting to say no to those medicines for prescriptions and us doing them in the pharmacy. So we've come away from doing that, and we've actually just started going through a further review, and that's because of the fact that the commissioning arrangements have changed. So we've done an in-depth review now about how we manage patients who come to pharmacy, etc. And we are going to, what's interesting is there's been a new nationally commissioned service around emergency supply, etc. And you would think that the local commissioners would then discontinue it. But the reality is that it's not as comprehensive as our schemes, and we have found that they've had such an impact on the system that we are still going to commission emergency supply even on top of the national system, because we know it's having significant impact on the volume of activity through into primary care and the urgent care system. So we're going to continue with the PGD work, going to change those around issues of conjunctivitis, and also changing the medications to keep up with new guidance. But we're also looking now at things such as what can we do around the independent prescribers that are beginning to emerge in community pharmacies across the pitch. Can we use those in a larger quantity to actually start impacting on demand even further? The whole purpose of this is to take demand out of the primary care system and the urgent care system. The other thing we're looking at is minor injuries. To what extent can we use those? So they will be played back in later. And so we've basically had a logical development here from starting with the PGSLs and the PGDs to actually getting to a point where recognising the system is changing, and going forward we're looking at how we extend that provision in independent prescribers, how we can take even further activity out of the system. But clearly, you know, we know now that we are actually having quite a significant impact on the demand that's going into primary care.
What we did differently in this setting, we came together, and from then we started developing that relationship between GP surgery and the pharmacy. We creating the pharmacy we're creating as an integrated health hub, as a pharmacy first contact of the patient, if that will be for repeat dispensing prescriptions, prescriptions, or would be as a walk-in clinic basically for triaging and saving GP appointments. So we created procedures for each conditions, which they could be referred to a pharmacy, where we assess and we could treat them for PGDs and any acute, more complex cases. We can refer back to the doctors, which they're happy to fast track them, and with the pharmacists see them between the patients if needed. With working sessions in practice, I'm seeing again the same population, so I have greater relationship with patients. They trust me, and in this way I can in both places provide holistic care, because in the pharmacy they feeling more relaxed and finding pharmacists more approachable. I can give them more time, and there's no waiting time in the pharmacy. You can basically walk in and being seen in 5-10 minutes. I have full access to GP notes both places, so at the surgery and in the pharmacy. So when the actual acute case is presented, I can actually put my notes straight onto the System 1 GP. As David said, all the PGDs in place, smoking cessation, flu vaccination, so we do all the complex care in the pharmacy. In addition to that, there's a minor injury unit next to us as well, which is led by nurses. Waiting time again, a couple of hours for minor ailments, so they're happy to refer any simple cases to us as well. An example, lady with skin infection, that was infected boil. She rings in the morning, there's no GP available, one of the locums rang sick, and she can come to us. Obviously, at the moment, we cannot treat the skin infections as yet. We're in the process of setting treatment plans for that. But again, I can assess simple infections. I can refer for any more complex, urgent cases back to the doctors with the recommendation which antibiotic to choose, and this patient can be seen quicker if needed. My advice to everyone working at the GP practice: go out there, invite the pharmacists, local pharmacists, to your clinical meetings, and start that working relationship with the local pharmacist. You don't have to actually pay them straight away, hire them. They actually, your local pharmacist will be more than happy to collaborate, because they know the patients and they know their needs, and they will be eager to care for them, because that's what we do. We're used to running walk-in clinics, because that's a pharmacy nowadays. That's what it is. It's just to upskill, that's what you have, and get them working together with you.